just wrapped up a very exciting discussion about the LAURA study, and now we're going to talk about big changes in small cell lung cancer and what that means for our patients as presented at ASCO 2024, specifically the Adriatic Study. Let's open it up with a case discussion here. So we have a 70-year-old female. She's got a 50-pack-year smoking history. When we think about her as a whole person, not just her cancer, she's also got some other medical concerns, including coronary artery disease, ended up having to get some stents put in to address that issue. But over the last 4 months, she's been unintentionally losing some weight. She goes to see her primary care doctor and they get some basic routine labs and they see that she's got a low sodium value of 126. While she's talking with her primary doctor, she starts to talk a little bit more about some other concerns that have been bothering her. More short of breath. She's starting to cough a lot more and has a productive cough, meaning that when she coughs, she takes out some sputum, some productive sort of material comes out when she coughs. So then she ends up getting admitted because her doctor is really concerned and they end up doing some imaging. The imaging here, if you look at it, we're looking at the left side over here where my pointer is, and then this is the right side of the chest and the lungs. You see this lung mass in the left lower lobe of the lung, and that's concerning, and it prompts more workup. So we need to figure out what that lung mass is. So we call in our colleagues in pulmonary medicine, and they help us do what we call a bronchoscopy and an ultrasound that's attached to that. And they're able to get in there and sample this left lower lobe of the lung. And what we find after we take that sample, give it to our pathologist, is that the patient is now diagnosed with small cell lung cancer, which is a very aggressive type of lung cancer. Occurs in about 15% of patients with lung cancer, but a very aggressive one. And this is an important number for us as medical oncologists, the Ki-67, it's 90%. And the way I teach this to patients is I say, hey, listen, that number can go from 0% up to 100%, and it tells us how aggressively your cancer is growing. So for it to be at 90%, that's quite high, and again, very aggressive and classic for small cell lung cancer. When we're thinking a little bit more about how to finish staging the patient, we also want to sample some of the lymph nodes that may be involved. And so that's a very common site where the lung cancer can travel. So our pulmonary medicine doctor appropriately samples some lymph nodes that are along the airways on the left side and the right side, also samples some lymph nodes that are in the middle of the chest, but they all come back negative for cancer. We get some additional imaging workup to make sure that the cancer has not left the lung, and thankfully we do not see that it has. We also want to check an MRI of the brain, and it shows us a meningioma, but that is not related to the small cell lung cancer, and so we can say there is no evidence of metastatic disease that's traveled to the brain. She's also going to get a PET scan just to complete our full workup. So let's pause there. Maybe Dr. Rose, I'll ask you this question in two ways. Before June 2024, what would you have done for this patient? And then after June 2024, what are you doing now?
So yeah, I think there's been a big pivot in how we're approaching this ever since the data presented at ASCO. We have been using platinum etoposide regimens for small cell lung cancer for essentially since I was born. By platinum, we mean either carboplatin or cisplatin with a drug called etoposide, and we would give these through the vein. And this would be it is still one of our best treatments for small cell lung cancer. We used it in an advanced setting. But then when you get into limited stage setting, we're thinking about how we can cure this patient. And as you said, this is unfortunately a very aggressive disease. And even the patients that we put the full court press on and do our best to try and treat this disease, we still have really disappointing results. So back before this new data was presented, I would think about doing chemotherapy plus radiation, sort of our old paradigm of putting chemotherapy and radiation together to treat this disease with a cautious curative intent. But now we have seen the advent of immunotherapy coming out, and I know we're going to be diving into that data. So I'm thinking about adding some immunotherapy into this patient's life. So we're drifting into one of those chemo radiations with the addition of immunotherapy options that we see near the bottom.
Perfect. Well summarized and really highlighting sort of the paradigm shift that's happened for these patients with small cell lung cancer. I'm going to quickly review that here too. So kind of before June 2024, this is where we were. We were using for patients with limited stage small cell lung cancer. I'll actually define that now. What that means is that the lung cancer is confined to one side of the chest, and it can also fit within one radiation field. And so for these patients, we do recommend platinum chemotherapy that goes along with radiation therapy. And that's been our standard of care, just like Dr. Rose said, and you can see it here listed on our NCCN guidelines. And really, that's been our standard of care for 40 years, 4 decades, where we haven't changed much for patients. The only thing we've really looked at was maybe how do we deliver the radiation with the chemotherapy? So do we give it once a day versus twice a day? And you can see here that overall for median, how long patients are living after they finish chemoradiation therapy, it's 25 to 30 months. When you look here as well, thinking about 5 years later after patients are done with chemoradiation, unfortunately, most patients are not with us, which is heartbreaking to see. Chemoradiation is not easy. It's weeks of treatment. It is a lot of supportive care that's needed. And we're trying to aim for cure, and then we end up with outcomes like this. So, of course, the question is, can we do better when we're not curing most of our patients with limited stage disease? And so that's where the Adriatic study comes in very nicely. This was presented by Dr. David Spiegel at ASCO 2024, and it included patients with limited stage small cell lung cancer. They had to have finished chemoradiation therapy. And importantly, before they got onto this trial, you had to make sure that their disease had not grown or progressed. And they were randomized into 3 arms here. So one was with durvalumab, which is a type of immunotherapy that's very commonly given in non-small cell lung cancer, for example, and in patients with extensive stage small cell lung cancer, or they were randomized to receive placebo, or there was a third arm where they had 2 immunotherapy drugs, durvalumab and tremelimumab. But this one is blinded for now, so we don't know the results. So really what was presented at ASCO 24 was this green box here. And the patients could receive treatment for up to 2 years. And what the researchers were looking at were 2 primary endpoints: how long patients are living, overall survival, and progression-free survival, meaning how long a patient can go without the disease coming back, progressing, or recurring. And you can see here overall in both arms, the immunotherapy arm and the placebo arm, pretty well balanced. But I just want to draw your attention to one thing. We did a really nice job recruiting patients who are white, who are Asian, but we need to do better for our patients who are not in those 2 categories. All of us can do better to improve diversity, inclusivity, and clinical trial enrollment. So this is just a quick call out for that. I'll also highlight here that the radiation schedule, most of these patients actually got once daily therapy, and most of these patients actually got cisplatin. So just something interesting to think about. I'm going to jump right into the lead sort of conclusions here. Overall survival, how long patients are living. And what you can see here is that you want to be on the durvalumab arm, the immunotherapy arm, as opposed to placebo. There was a clear median overall survival benefit. Patients 56 months who received durvalumab versus 33, hazard ratio of 0.73. I'm going to blow it up again and also put in my interpretation. That's almost a 2-year improvement in how long patients are living with the addition of one immunotherapy drug for up to 2 years, the durvalumab, which is quite incredible to see. And we have not seen an update like this for patients in extensive stage small cell lung cancer and definitely limited stage small cell lung cancer in over 40 years. Incredible. Looking at just quickly which patients are benefiting, you can see that for the most part, regardless of different patient characteristics, they all appear to be receiving a benefit from durvalumab. There's some nuances here, but again, the numbers kind of become very small when you break it down. This is a subgroup analysis. Thinking about progression-free survival, you can also see a benefit for that too, meaning how long a patient can go without the disease coming back or growing or being concerned about that. And median progression-free survival was 16.6 months versus 9.2 months for placebo, hazard ratio of 0.76. So again, another positive endpoint that's showing us that patients are indeed getting a clinical benefit from the addition of immunotherapy. Of course, we got to stop and pause because this is a moment to celebrate and say, yes, we've achieved some updates and benefits for our patients clinically. But what about the toxicity effects, right? With every type of treatment we enter into the paradigm, there's also a potential for toxicity. And so lots of great questions here. Maybe Dr. Saxena, I'll ask you one of these questions. One of the things we worry about after a patient gets significant amounts of radiation over time is this inflammation of the lung, pneumonitis. And we know that immunotherapy can also, in a different way, cause inflammation of the lung, which is also called pneumonitis. How concerned are you now that we're adding immunotherapy after radiation and developing this type of toxicity?
Yeah, no, I think that is a really good question, which I think they tried to address in the study specifically. It's definitely something of major concern because pneumonitis is something that is very serious. It affects how well you can breathe, and even after you are able to control it with steroids or do something about it, sometimes at the end, unfortunately, there are some patients that'll still be left with not breathing as well as they did beforehand. So there can be some more long-term and even permanent damage to your lungs. And then there are some, thankfully more rare cases now where it can be fatal. And so it is a very concerning toxicity in this situation. And as you mentioned, Dr. Singh, this is something that we see with both radiation and immunotherapy. So when you do them one after the other, you definitely have a heightened concern for this. But I believe, as we'll kind of go over, they didn't seem to find a huge difference in the amount of pneumonitis in this, which was very reassuring because I think that was something that a lot of us were worried about. We're going to do this and we're going to cause more harm, even if we do improve their survival. It may come at a really high cost.
Absolutely, that was really well put. Let's jump right into kind of how things were tolerated for these patients on the trial. So they broke that down for us very nicely in the presentation. I put a summary here on the bottom, but basically in the patients that got immunotherapy, their durvalumab, only about a third of patients were actually able to complete the full 2 years of therapy that was recommended on the trial. And the reasons why, so half of the patients ended up experiencing disease progression, meaning that their disease was growing and coming back. But also 16% of patients had to discontinue treatment because they experienced a side effect that was not tolerable. So breaking those sort of side effects down, we've talked a little bit today, this common theme of really focusing on grade 3, grade 4 adverse events or side effects, the really scary side effects, if you will. If you look at the buckets here between placebo and durvalumab, it's about the same. 24% of patients experienced grade 3 or grade 4 adverse events. And again, 16% of patients had to discontinue treatment with immunotherapy. We talked a lot about a concern for pneumonitis, that inflammation of the lung, and the investigators actually broke it down between radiation pneumonitis, so inflammation of the lung caused by radiation, and then pneumonitis just in general, not really attributed to the radiation. And you can see that the leading adverse event side effect, regardless of if you got immunotherapy or the placebo, was indeed radiation pneumonitis. But of course, there are some variable side effects here based on the treatment that they got, including hypothyroidism, more specifically for patients with immunotherapy, as well as pneumonitis. Let's focus a little bit more on just in general radiation pneumonitis and pneumonitis. And you can see here that the maximum grade 3 or 4 for patients that got immunotherapy and had pneumonitis was 3% of patients, and it was 2.6 for placebo. So that's not a big difference here, which provides a little bit of reassurance, at least for me. I'm going to pull you guys in a little bit too. But also we want to think about, we have some experience already for patients with non-small cell lung cancer, a more common type of lung cancer, who have been receiving this type of treatment paradigm for some time now. And that's based on the Pacific study, where they got chemoradiation. After chemoradiation, they got 1 year of durvalumab therapy. What was going on with inflammation there? And it was about the same as what we're seeing here, right? That 30-ish%, grade 3, grade 4, right around 3%. So it sort of mimics that same toxicity profile that we'd expect. I'm going to throw in a curveball here, and then we're going to ask Dr. Prishagul what she would do. So this patient is completed chemoradiation therapy. Before they got on to the immunotherapy by itself, the medical oncologist appropriately checked a scan and saw that there was a treatment response, no concerns for the disease growing. So then they started them on durvalumab, that single agent immunotherapy. And they've been nicely going through immunotherapy for 6 months, no toxicity. And then they get a scan. And unfortunately, we hate seeing this. You see progression, that the cancer is growing. So Dr. Prishagul, what would you do now? Would you give another round or challenge of chemotherapy with maybe some more immunotherapy or some of these other options? Talk me through your thoughts.
Yeah, so I think unfortunately we see this too commonly. Patients with small cell tend to have a very robust response up front, but we know that response time is limited, right? So I always say, like, the bigger they are, the harder they fall. They come in hot and they melt very quickly, but then oftentimes come back kind of with a vengeance. So we have to think about platinum sensitivity in this setting, right? So you have somebody that has progressed. Basically, you need to think, did their cancer grow sooner, like within 6 months of them being exposed to carboplatin and etoposide, the chemo portion, or was it after 6 months? So in this patient, it was kind of right at the 6-month mark. So I think it needs a risk versus benefit. And I designed it this way so we would have this kind of talk and it wouldn't be so straightforward. But I think, right at the cusp, I always tell my patients, it's possible, right? It's possible your cancer could be sensitive to exposure to the same chemo regimen that you got before. So you always want to try to keep someone on the same line of treatment or not expose someone's cancer to a new kind of treatment unless you absolutely need to, because while we're very fortunate that we have some of these other lines of treatment now, we have lurbinectedin, we have tarlatamab, newer on the block, and other second line options here. we run out of options, unfortunately, too fast. So if I have someone that I think could potentially benefit from carboplatin and etoposide rechallenge, then I would offer it. And I think I would discuss it with this patient if she tolerated it okay. And I think it would be reasonable to try, but I would only give 2 cycles and then I would scan again very quickly. And if it seemed like things were responding, then we would then go ahead and give the additional 2 more. But if it looked like things were progressing, then I would be at that point be very quick to switch to either lurbinectedin, tarlatamab, or a clinical trial. In regards to choosing if I would add immunotherapy or not, I don't see why you wouldn't, right? I can't say that I would use durvalumab again, but do I have real science to explain if I think atezolizumab would work in this setting? Maybe, maybe not, right? But I think it's worth a shot to try a different IO agent. Like sometimes they even say if you have an infusion reaction to one IO agent, you can try a different IO agent, whether it's PD-1 versus PD-L1. So I think I probably would just go ahead and try atezolizumab in this setting, but I don't really have any data to support that. I'm just being candid. But I think why not offer it?
Yeah, I think you really nicely walked us through all of these potential options, highlighting, the thinking about that platinum sensitivity period, which you defined really nicely. Like, is there an opportunity to re-challenge the patient with a type of chemotherapy that they've gotten before? Most of us say 6 months, but that's also kind of controversial, right? So some of our colleagues, in Europe, for example, think about even 3 months. But that's something to think about. I think second, you also pointed out the importance of clinical trials, right? Especially in this setting. So if there's an opportunity for clinical trials, if your patient is motivated and you're thinking about it, definitely explore options. That's listed on the NCI actually as a NCCN as a category 1 recommendation in this setting too. So definitely something to think about. And then third, thinking about, do we reintroduce immunotherapy? Do we not? We don't really have the data. And I think it really does depend on the shared decision-making sort of a situation and then thinking about what to do. So nicely highlighted. So these are just quickly the author's conclusions. My interpretation in the bottom there, these results, in my opinion, are absolutely practice changing for patients with limited stage disease. If I saw a patient with limited stage small cell lung cancer after ASCO 24, that Monday, I would absolutely discuss this and really talk to their insurance about getting this approved. Second, we're seeing a 2-year improvement in overall survival, how longer patients are living on sort of the median average there. And that's unprecedented in this space, so really important. And then third, one of the concerns many of us were really worried about was inflammation in the lung, pneumonitis. And overall, it seems to be reassuring, which provided some comfort in me recommending this. So thanks for chatting with me about the Adriatic study, and then we'll hand it off for our next discussion.